getting to the plane first time, about 25 of my family members there to see me, send me off from the airport. A friend of mine said, there is a guy called Ashok. He's my good friend. You meet him in the airport. I was so glad I'm going to meet somebody who lives in UK. So I met him. I was blown away. So nice, so friendly. He said, Chandru, come to London. I will look after you. I will help you everything. Which was to me a great surprise to a level and also more comforting. I came here, went through the usual flab routine, everything. I went to his house first time. What you see? About 10 dogs, everywhere running around. He is one of the loveliest person, loves the animals so much. He loves everything, human beings, plants, animals, everybody. I haven't seen anyone who can say, yes, I will help you. He doesn't know no at all. He will help everyone. And from then my relationship started. He arranged my first job in UK, which is the most difficult for any foreigner coming to UK first. And then I took off. Unfortunately, we lost track. I moved in a different direction, not to his place. But every registrar trainee worked in, I think it's Hammersmith, St. Mary's. And also he moved to Leeds for a while. They all will talk so fond of him. It was Ashok Cherian, Ashok we call him, who gave everything, starting, advice. Nobody is no good. Everybody he will help. And a lot of them who are now consultants went on from where he started their career, helped with their career. He went to Australia, worked with Dr. Ross or Mr. and they call them Dr. Ross, different Ross. But in UK, he was kind of right hand for Mr. Donald Ross and this, Sir MacD Eku. They will operate and go. He will look after everything, coming in the night, ward round, morning round, evening round, etc. Even looking after the outpatients. He was like what we call a yo-yo boy. Come on, go and do this. He will go to every private hospital, look after their patients. He also looked after shopping or helping them with everything else. And then I met him again nearly 10 years, 15 years later. And then we loved going to a vegetarian Indian restaurant in Tooting to have our dosa. He loves the South Indian food so much. He comes from Chennai, even though he's by birth Kerala man. But it's something I will never forget, to see such a wonderful human being who only knows how to help everybody else. He comes from a very high-class family, very philanthropic family. His father was dean of the Madras Medical College, one of the oldest medical colleges in India, Chennai. And his mother was a big social worker, well known in India in her days. And his father went on to become the governor of Mumbai, now called the olden day Bombay state. And he had a lot of contact with many diplomats, professional people, and he got trained in MCH in Mumbai and then went to Australia and here. Again, the statement there, it's kingly to act assistant, the follower. He is so good. This is the governor house in Bombay. You can see Ashok as a little boy. He always says, I am an accidental birth, because he was about 15 years younger to every other siblings in the family. He was very looked after, very jolly good guy. He came to UK to tell how he didn't bother about himself, only about others. He had not a single penny in his pension fund. He spent everything for everybody else and for the dogs. And when he was working with Donald Ross, he met his secretary, and who became his wife, and she is here with all of us today, Fiona. And they both are such animal lovers, horses for Fiona and dogs for Ashok. Shall I use this?
There you go.
Okay, this is some of the photographs. Ashok grew during the period of early parts of surgery, where they used to cut and pericardium suture on the frame. He did it in India. He was involved in the monkey transplant to learn about it. Then when he came here, he was with Donald Ross, all the stories about how Donald took the heart out of the patient, replaced the mitral valve and put it back. This is what, he will confirm it, how he did the mammary was injured, so he grafted the distal mammary to the LAD. So when you meet Ashok, you hear so many of the interesting conversation of past happenings in the field of cardiac surgery. And that is Ashok, the young Ashok with a patient. Here with Donald Ross is unrecognizable with a bow tie and thin, lean man. And here he is reading. Next slide, please. All right, that is Fiona and Ashok. And oh, it's a cat or a dog, Fiona? Everything was there. That is one of his dogs. And in the end, he had one dog, and he was saying, I'm very sad about leaving this world because I am sorry to leave the dog. He was more concerned about animals so much. Oh, yeah. This is Professor Tyrone David Ashok. It's one of the core meeting, was it? Okay. This is again core meeting in Royal College with all the friends. This is he organizes with the in Leeds the surgery training programs. He was without any hesitation. Oh, I'm ready. I'm coming. I will help you. He wasn't looking for glory or anything. He doesn't need to be in the paper, print out anything. Is that it? Ashok, rest in peace. One of the finest human beings I have come across. Thank you.
Treat aortic root aneurysm. Anatomy is an indispensable part of surgery. If you want to be a good surgeon, learn anatomy first, and then physiology. And then by the time you add pathology, you know how to fix the problem, because pathology alters the anatomy and function, and it is your role to establish normal function. When you function the aortic valve, you have to consider not only the aortic cusps, like the mitral valve. They are the most important part of the aortic valve, but the entire aortic root. The aortic root starts where the ventricle ends, and it ends where the ascending aorta starts. Therefore, both the ascending aorta and the left ventricle plays a role in the function and anatomy of the aortic valve. It's a complex structure like the mitral valve. The cusps are attached to the junction between the aorta and the ventricle, and we call the junction aortic annulus or aortoventricular junction. And the aortoventricular junction varies slightly among us. However, if you take a look at the circumference from behind the left main all the way to behind the right coronary artery, it's all connective tissue, it's fibrous tissue. And then from the nadir of the right cusp to the nadir of the left, where the lot of fibrous trigone is muscle. So no cusp is entirely attached to muscle here. The left and right are half and half, and the non-coronary cusp is entirely attached to fibrous tissue. The fibrous tissue this morning described is called the intervallar fibrous trigon, but extended in spaces way inside the aortic root called the subcommissural triangles. They belong to the ventricle or belong to the aorta? Well, be as you may, you can call whatever you want. The important thing is those triangles play a role in aortic valve function. Because if the form alters, for instance, you have a connective tissue disorder like Marfan syndrome or this part here is going to dilate, is going to expand and cause what they call the annulo-aortic ectasia, the big annulus. It may or not be accompanied by large cusps. If the cusp is normal and that tissue dilates, you can develop aortic insufficiency because your arteries become so big, the area that the cusps can seal is inadequate. How about pathology of the aortic root? Well, there's a number of disorders. The most common one, again, like in mitral valve, is degenerative. But you can have inflammatory disorders, you can have infection, aortic dissection, and some congenital problem. By and large, the most common one, and 1% of you have that, is bicuspid aortic valve. And less common hypoplasia and aortic stenosis. We can't, in 30, 40 minutes, describe everything to you and how affect our lives as a surgeon, except for the more common ones. The degenerative disorders of the aortic root can cause two problems. One I personally call the primary disorder. The disease starts in the aortic root. And the aortic sinuses dilate first, and that's the natural sequence of the evolution of the disease. The aortic sinus begin to bulge. The stress on a junction increases. So frequently, the aortic annulus, you dilate because it's the same disease, connective tissue disorder. Unfortunately, those patients are very young. They express in childhood, when they are 10. The peak incidence is between second and fourth decade. Between age 20 and 40, 45 is the highest incidence. And frequently, if you investigate, if you interrogate enough, they have a genetic syndrome associated with them. Familial aneurysms, a sporadic but a brother head or a distant sibling, or a well-known syndrome like Marfan syndrome, which is the most common one. Secondary aneurysms are diseases of the ascending aorta. It starts in the ascending aorta, and it propagates both ends, goes up the aortic arch. It might involve the innominate artery, more often not, and it propagates downstream as well into the aortic root. The moment it dilates the sinotubular junction affects the aortic valve function. The aortic valve is very elastic. It can accommodate 10, 20, up to 30% dilatation without affecting function. So it goes undetected. And the sinus then might become dilated. This disorder, the aortic annulus is invariably normal size, small, 19, 20, 21 millimeters, like most of us have. It occurs late in life. The guy was 50, 60, 70, 80-year-old. And, but even that, if you speak to them, they say, well, I had an uncle who died from dissection, or I had a brother, distant relative that had the problem. The genetic syndrome ones are, well known, are the Aneurysms, Marfan, the most common, Louis-Dietz, which is a dreadful syndrome to have, depending on the type, but by and large, dreadful. Aneurysm osteoarthritis has been described, but is rare. Transforming growth factor aneurysm, relatively rare. And usually, if you investigate them enough, They end up being a Lewis syndrome, type 1, and other ones as well. The second most common are the familial aneurysms, and then the sporadic, we believe, genetic mutation. Why have to treat them? Well, because if you continue dilating, the aortic valve becoming incompetent, it causes AI can damage the heart. Or the aorta can rupture, and then it's not your patient. They die suddenly, and there's no way to save somebody who ruptured the ascending aorta. They exsanguinate in no time. It can be ruptured after dissection as well. They dissect first and then rupture. Those we don't see either, because most of them tamponade and die at home. By the time they get in the hospital, they are dead. If they are lucky enough to be contained, like ruptures in the intima only, then you can do something about it. But that's why operation should be done. Well, when do we operate these patients then? We don't know. We use size and family history. If they have a very strong family history of the aortic dissection, aortic rupture, we have to be a bit more aggressive. But we don't have a good test to say, operate now. We're looking for. So size is the most important one, and size means you're basing yourself on wall tension. Your tension becomes, but my body surface area is 2 meters square. A 50 millimeter on me does not have the same effect of a 50 millimeter in somebody whose body surface area is 1.5. You better be more aggressive in the smaller one to be out of proportion. But the size is the same, the tension is the same. Why not be more aggressive? Well, because you rupture more often in a smaller person than a big person, and I don't know why. Surgeons develop a new index called the aortic size index. It doesn't correlate too well, but that's the best we have. Again, size is the marker. In Marfan syndrome, 50 millimeter. Every other one, 40 to 50. Lewis, anything over 40, surgery. Familial aneurysm can be a bit more tolerant, and the sporadic one the same way, because you don't have enough data. If any of these patients tell my brother died of dissection, then a red light goes on. Doesn't matter if the aneurysm is 45 in Marfan's. If you can do an operation safely, you should operate on them to save their lives. The problem of aortic root aneurysm associated with genetic syndrome is that the problem is not only the sinuses that bulge, is the inside, is the annulus. The aortic annulus has 3 subcommissural triangles. Those triangles being very acute becomes obtuse. So it shortens the height of the cusp, and they cannot close properly. So if you're going to address the issue, you have to think of that, how to reduce those, the shape of the subcommissural triangles. Of course, the subcommissural triangle between left and right cusp won't dilate, it's all muscle. That's pretty fixed. However, the ones of the non-coronary cusp, in other words, non-coronary and right, non-coronary and left, those are dilated mostly. That's why frequently the non-coronary sinus is much lower than the other sinus. It becomes like a, not only dilated, but a bit of cockeyed aortic annulus. The aortic annulus, if I measure all of you, it's maybe 100 of us here, 80. If you do an echo on each one of you, your average aortic annulus is going to be 19 millimeter. The lady is a bit smaller, the man a bit bigger. But it's a function of your body surface area. The best study on aortic annulus was done based on geometry by putting a Hager's dilator in 4,000 aortic homographs from age 16 to 40. So relatively young people, young adults. That's me. So I didn't believe when I first read this paper in the year 2000. So I did an echo myself. Bingo, 21 millimeter. My body surface area is 2. The average aortic annulus per 2 should be 22. Mine is 21 by echo. And I got in multiple views, 21 millimeter. So my aortic annulus is 21 millimeter, my root is normal. The sinus are 34, 33 millimeter. So the aortic annulus is normally very small. So a person annulus of 30 millimeters is abnormal, is enlarged. It's a smart woman from Cameroon, daughter of a missionary that she immigrated to England, and then she saw a cardiologist in Oxford. And the cardiologist said, you should immigrate to Canada. This was 15, 20 years ago. She said, why? Because it's one of the best aortic root surgeons there, and the best back surgeon is there, coincidentally in the same hospital. So if you can get to know them. So she found a job in Halifax, and sure enough, a year later, she was in my office. And this was so big, I said, you can't have your back fixed, severe kyphoscoliosis. This is her aortic root, minimal AI, but 29 millimeters, and she was this tall. This tall because logically she was deformed, and if you freeze us apart, it was 29 millimeter aortic annulus for a person whose body surface area is 1.5, it's massively dilated. So she had that aortic root fixed, and 5 years later, she was back in Cameroon, tall. She was 145, she became 160 tall, because all full of rods in her back, but doing very well. The other type of aortic root annulus is a secondary one, the one that starts in the ascending aorta and then retrograde propagates to the sinotubular junction, and eventually the aortic sinus become dilated. But the ascending aorta is big as well. The aortic annulus, by and large, is normal, because if it's not, likely they have a genetic syndrome. There was a late expression, but they still have family history, and happen when they're 60, 70, and 80-year-old. That's how it looks in the operating room and in the echo. Tiny, tiny annulus, huge ascending aorta and aortic root. When you imagine the annulus, a man almost my size, 1.8 body surface area, the aortic annulus is 21 millimeter, 21.8, so 22 millimeter. And the ascending aorta is quite large, 5.25 the ascending aorta, the sinotubular junction is 4. This aneurysm and this one here are very different. You cannot have the single operation for both. You can try to do a single operation for both. In other words, do a benting, all of them, and then solve the problem. But time has come for us to be a bit more specific in therapy, or patient-guided therapy. So they have an aneurysm. If the aortic annulus is entirely normal, this is a great operation. If the aortic annulus is normal, the cusps are normal. If the cusps are diseased, stenotic or all torn or full of the defect, then you replace the aortic valve. You can replace with a mechanical valve, or you can replace with a tissue valve, suture inside of a, or use a homograft if you like. The problem with the homograft is a limited durability, just like a pig valve. It's not more durable than a pig valve. But if you do this operation, then you can have a TAVI, or if they come to you for reoperation, you don't have to do a whole bent again. You simply take the bioprosthetic valve out, put a new valve in, leave the coronary arteries attached to the heart. That's how you should do a bento with the bioprosthetic valve. If you do one of the fancier new operations that we developed over the years, and the original one came from England, from Sir Maggie Yacoub. He was supposed to be here, no? He developed this procedure here. Unfortunately, again, he didn't publish until later. We were unaware when we developed this. But it goes to show that if you read enough, you find out what you are doing is not original. We made this operation very complicated because we were doing an annuloplasty and then remodeling the aortic root upstream. So after 2 or 3 of this, we had the idea why not to do a single one, put the whole thing in a conduit, and reimplanted the native aortic valve like you are implanting an aortic valve homograft. A surgeon from Florida, from Gainesville, called Thomas Martin, published in 2005, said, if you have no AI, why to replace the sinuses? Wrap the whole thing with Dacron. And then here in England, an engineer who had the Marfan syndrome developed a mesh with the same purpose, and he had himself this operation. Unfortunately, in either one, there is long-term data or consistency on how it should be done. And if you are facing with a patient with an aortic aneurysm, that the size dictates an operation, and the operation, the patient is relatively safe. In other words, the disease is more likely to kill the patient than your operation. And that's how we should decide every time we make a decision to operate. If the echo shows normal aortic cusps, might be incompetent, might be leaking, but the valve, the cusps move normally, not calcified, it's not narrowed. Consideration should be done to a conservative operation called the aortic valve sparing. I first published this in 1992. I have traveled to 59 countries and open heart units to teach this operation. There are over 1,000 surgeons on my list that do this operation in the world now. Aortic valve sparing, everywhere, in every continent. One of the lowest one is in our country. Socialized healthcare, very advanced. Everybody has access, but you have on the lowest. And ironically, if you go back to history, I'm sorry that Sir Magd is not here. He did this operation as far back as 1970s. They never published because too busy again in those days to collect this series. But he told me that 1973 he did the first one. He did the remodeling the aortic root, so much that the operation carries his name now. It's called the Yakub remodeling. I don't know why your surgeons don't want to do this in England. Even Americans, this competitive practice they have there, they are now approximately 20% of the aortic root surgery is valve sparing. Of course, the second one, if you do for a patient normal aortic valve, that's okay too. And if, as long as it's safe and as a safer operation in your hand, you do what's safe for the patient, not what is necessarily best for his lifespan. This group here is the worst because they have very severe aortic connective tissue disorders. Marfan's, like Lou-George syndrome. In 1988, I started doing these operations. We published this on JACC last year, so this information is available in the literature. I had personally done 193 patients with Marfan syndrome that get referred to me. 189, 98%, that means the vast majority, had an aortic valve sparing. 164 was put in a tube, and the remaining had the remodeling. Only 2% had a valve replacement. They're very young, 36-year-old, the mean age. For the last 20 years, I stopped taking a call. That's for the young people to take calls. So I don't do many dissections, so only 10 of the patients had the aortic dissection. 10 acute, and the 4 had survived the acute dissection and came in more electively. And 2 had a B dissection with nothing to do with the aortic root. 5% had bicuspid aortic valve, and the vast majority had moderate severe AI before operation. So because the valve is incompetent, it doesn't preclude a good operation. 113 had the not tube, straight tube. In the 51, we tailored the diaphragm graft to imitate nature to create a neo-aortic sign of Valsalva, a technique that can be done to I don't know if it's important or not, but we are doing this now consistently. We do not use commercial Valsalva. I don't think it's the right shape. And the 25 patients who had Yakub procedure remodeling had a simple remodeling, 13, but the annulus was normal. In 12, the annulus was dilated, so we put a subaortic annuloplasty to reduce the annulus. And of course, the Marfan patients come for surgery, they don't need only a root operation, they need much more. So half of them had something else. What's the half that had something else? Well, they had aortic arch replacement. 2 had an elephant trunk because the whole thing was dissected. 4 had any arch. 13 had a VSG or atrioceptor defect, which is very common in Marfan's. 29 required combined mitral valve repair. 2 tricuspid. 3 had the maze. 7 of them are old enough to have developed coronary artery disease and required coronary bypass at the same time. And 1 had a large abdominal aneurysm. We fixed at the same time on bypass, which is very nice way to do abdominal aortic aneurysm. Don't have to worry about clumping and unclumping on this. 1 patient died 2 days after the operation. Doing well, was walking, he fainted and developed a B dissection, MO perfusion. We demonstrated, we tried to put a stent, but still died. Died from death of the gut, liver, and splanchnic area. And 36 died late. That was very distressing for an investigator because they're only 36-year-old. So, 21% died within 20 years. They should be all alive. They all should be 56-year-old if the operation is that great. Well, then it's your job to find out why they died. Well, they died because of, at 22, died from cardiovascular-related causes. Complication dissection, like the falso lumen rupture or require more surgery. 6 died suddenly, indicating that likely the aorta rupture somewhere. 2 developed Marfan's cardiomyopathy and died heart failure. 4 suffered stroke. 3 of them hemorrhagic because of intracranial aneurysms, which is an associated disease in Marfan's. And 2 suffered myocardial infarction. They both had coronary disease. And 14 non-cardiovascular related, 2 emphysema, 1 polycystic kidney disease, largely related to Marfan's as well. It's a systemic disorder. It's not only heart. How about the reoperation? Well, very, very few reoperation reimplantation. We had a 22% of reoperation remodeling. So even putting a band beneath, the tissue in between continues to dilate. So we personally believe the only operation for Marfan's or anyone to connect tissue disorder is reimplantation. That's why I wish Sir Michael was going to come to see this to criticize me, but try to defend his procedure. How about the aortic insufficiency? Well, if we have more rehab, infraction, develop type B dissection. This happens with bento, with any operation happens. So we don't cure the disease, you solve the problem, the aortic root, but we are still exposed to mortality and morbidity due to other related diseases associated with Marfan's. summary was like that. Morbid event at 20 years. 21% died, which is, this is a very high mortality because we're at only 36 when they start. In all patients, 14% develop moderate or severe AI. However, if you break it down according to the operation, very uncommon in reimplantation, common in remodeling. So this, we surgeons can fix it. At least I fixed in my practice. I don't do this operation anymore in Marfan's. I do only reimplantation. I continue doing remodeling in older patient neuromyelitis, but not in connective tissue disorders. Reoperation in all patients, 7.5% at 20 years. Reimplantation, only 5%, and 4 times more there. But that's the devil here. The devil that we don't know how to cure, how to prevent that. And they're all taking beta blockades and ACE inhibitors. We discharge them all the Marfan's. Aortic valve sparing, and in particular the technique of reimplantation, the aortic valve are associated with low valve-related complications. So you solve the aortic valve problem. Distal dissections remain an unresolved problem in patients with Marfan's. Our experience with low edits and other connective tissues are identical, that can be overlapped to this one here. So all the genetic syndrome carry the same problem. Very nice, Dr. David. Are these results reproducible? Because if I'm the only one who can do this, trash it. It's no good. Well, the Marfan Foundation is an organization in the United States that raises money to support the research to improve the life of patient Marfan syndrome. They're intrigued by my publications on this, and in 2005, they connect with several American heart surgeons, many of them, who call themselves aortic surgeons, to do a trial. It's going to be prospective, multi-center, comparative. When I was a consultant, I said, we have to randomize. They said, no, we don't know if the operations are good yet. This is observational. Let the surgeon decide what's best for the patient, and then we follow the patient. Seemed like a waste of money to me, but it's okay. So they recruited from 2005 to 2010, 46 American heart surgeons operating 316 Marfan's patients. Every time you read a paper, something new, you have to know a bit of mathematics and basic arithmetics. 316 divided by 46, if you divide, it's going to be roughly 6.7, 6.8. And then you look time interval, 6.5 over 5 years, 6 years, means 1 per year. Monsieur Magdi just walked in. Hello, Magdi. Why didn't you bring to this door here? So those surgeons performed 77 bentos and 239, they called it David operation. However, all but 3 were Valsalva graft, which is the wrong graft to this operation because it's spherical. But marketing, the company sell as the graft to replace the aortic root. Even put a mechanical valve, they want to sell this. And they published recently the results. Survival was not much different. In blue is valve sparing, in red is replacement, bento. Then at 5 years, in blue is valve sparing. 30% had moderate severe aortic insufficiency or had a reoperation already. 5 years. Not 30 years, 20 years, 5. reoperation. It's way too high in valve sparing in reimplantation. The conclusion the authors came as we compared valve-related complications after aortic valve sparing versus valve replacement aortic root in patient Marfan syndrome. We found rates of major adverse valve-related events and morbidity after valve sparing procedures, mainly due to frequent valve dysfunction, meaning aortic insufficiency. Reintervention rates were the same because the patients who develop AI is well tolerated. They're not symptomatic. They're walking there, destroying their ventricles. Long-term follow-up is ongoing. If at 5 years, there's a 30% difference. At 10 years, it'd be tragic. It's going to be all either dead or reoperation. And years ago, in 2015, we published another paper in Marfan's population, and we compared the population in general of Canada. And survival, in spite of valve sparing, was not the same as population. Back then, we did not know why, because we didn't have enough sample size. Now, I just gave the sample size. When the sample size is doubled, it's because of dissections. So, valve sparing is a great operation for this population, but it doesn't restore their lifespan to normal. However, if you compare to Dr. Gott's, which is the largest longitudinal outcome publishing bentals in Marfan's, that's how it compares. That's what you do in red. And this is a very good institution, by the way. They have been taking care of the Marfan's forever. That's what he published as mortality of Marfan's patient at Johns Hopkins Hospital. If you take a look at the papers, at 15 years, 24% had died. And valve sparing, 7% only. Cannot compare, they're two separate patient groups, but they're the same age. They're both North Americans, serious. I think valve sparing is a bad operation for Marfan's patient. The problem is whether it's reproducible or not. Based on the National Marfan Foundation in the United States, it's not reproducible. In my argument and I wrote a letter to the Marfan, is this one here. This 46/315. If you do one operation a year, doesn't matter which operation you're going to do, whether it be a hernia repair or a carotid arterectomy, pull a tooth out in your mouth, you're not going to do as well as the guy who does one every day. There's no way. Repetition makes perfect. It's too bad Gebrin left because of, Gebrin is one of the surgeons that changed the way we treat bicuspid aortic valve. Another very common cause for aortic root aneurysm. Approximately 30 bicuspid aortic valve become incompetent during the first 5 decades of life. And what we learned is for all the types of bicuspid aortic valve, the most common, unfortunately, is type 1, severe type 1, where the two cusps are fused and there's one raphe or malformed, didn't complete the separation entirely. These are the best ones for valve sparing. These are the worst ones for valve sparing or preservation of the aortic valve. And this one here, according to Gebrin Al-Khoury, and I'd like him to be here to discuss, it depends on the angle. Gebrin believes that the way to treat incompetent bicuspid aortic valve is to reduce the size of the annulus, make the annulus very small. And he's an exceptionally good surgeon. He can do this operation. He dissects the aortic root down a centimeter and a half, below the annulus, and make the whole thing very small. Well, try to see how difficult it is. You enter the right ventricle, end up cutting the septum, end up making more mistakes than you can repair in the operating room. And the most important thing in surgery, I believe, and I try to brainwash my trainees, is bring the patient to the operating room, do only what you brought the patient for. In other words, if this is a mitral valve repair, you repair the mitral valve, but don't damage, don't dissect the aorta, don't tear the cava, don't tear the posterior wall of the heart, don't tear the cannulation, protect the heart, and the patient do well afterwards. The problem is when you do surgery, we frequently add more pathology, and that's why they die. That's complicated. And I don't know if Gebring's technique is reproducible, to be quite honest, because I tried, and I'm not a bad surgeon. And ever so often I put holes in places where I'm not supposed to put holes. In other words, cut the right ventricle, end up cutting the membranous septum as you dissect down to make the whole aortic root 180 degrees. So he takes in a valve like this and tries to transform the shape in a truly bicuspid. I think the best is if you have an incompetent aortic valve in a dilated aortic root, and the patient has two identical cusps, those are as good as tricuspid. We have no failures in the past 30 years in doing valve sparing in these patients. In the other ones, the jury's out there. If I can tell you that he fails with the standard operation. Gebring claims that if you do the way he doesn't fail, but only time will tell. So what he does is he take a patient like this, 34 millimeter, and it doesn't stop with dissection down here. He extends it down way in the septum. A centimeter below, that's a difficult technical task. Thank you. What applause for you came. Sir Mark, it's a pleasure to have you here. It's too bad, but I gave you credit on the early days of aortic valve sparing. And maybe perhaps you should educate us how you started in 73 when you started doing valve sparing. Replace one sinus, two sinuses.
May I ask a question, please?
Yeah, of course.
Congratulations on the results of the David operation, the valve sparing, compared to the general population and to the replacement. Am I right in showing the impressive survival curves you have just shown? My question is, why is there a continued attrition of the Marfan compared? It's much better than valve replacement. That's very nice indeed. But why is there an attrition compared to the general population? Is that due to something to do with the graft, with the valve sparing, or with peripheral things, and how can that be improved?
Well, I don't know the answer. The first part of the question is, we found out why now is distal disease. And the most common one, at 1% per year, is type B dissection. They develop B dissections. And the most common cause of death is complications of dissection. The aortic root itself was a very small 4.5% at 20 years. So it wasn't the aortic root.
Where was the dissection?
Distal.
Distally?
B. And they ruptured the false lumen.
Is there a way of reducing that?
Yeah, we are looking
by reducing blood pressure. I don't know what.
Yeah, we are. For the past more than 20 years, everybody goes home. Every Marfan's patient go home with beta blocker, unless they have asthma or something that contraindicated beta blocker. Then give a calcium antagonist and an ACE inhibitor. So they all get some control the blood pressure. How well is control at home? We don't know that. We do have a clinic to take care of these patients, and we stress the importance of oral hygiene, the exercise that they can do, and control the blood pressure. But in spite of that, they develop a big dissection. In Bentos is worse than that. In Bentos is 2% per year approximately.
Oh, absolutely. I mean, I could see that. But I'm just going for perfection. Is there a place, for example, for prophylactic stenting of the descending aorta?
There's a new stent now, Maral Ozania, the new present chief there. She has done in 3 cases already Marfan's. She does the valve sparing, and then she deploys, I don't know the name, a commercial name. It's a frame only. There's no stent. It's a stent. It's a not cover stent that expands. What is it called?
AMDS.
Yeah. She's putting in this patient.
What kind of stent?
It's a frame only. It's like a coronary stent.
Just strengthen the wall.
Yes. And
not cover stent.
and has a lot of, there's a new one, an antibiotic impregnated, which apparently promotes healing in the intima and slow down degeneration. But, you know, she just started 2 years ago, and to collect a large series. But it won't be very difficult to prove a difference, because the sample size doesn't have to be very large, given that conventional operations dissect 1% per year. So if you put this stent in 50 patients and show in 5 years there's no dissection, you might. And there's another engineer in our group, Jennifer Cheng. She's a heart surgeon engineer. She's measuring stresses there. It's a problem. Every time you replace the aortic valve or put a rigid structure in the aorta, the stress is propagated from here to the mid-aortic arch and distal aortic arch. And all of us, she has a normal patients who had the bento without Marfan's. On them too, the stress is increased. Why we don't dissect, and Marfan's dissect, or people who just dissect as well, is because of the connective tissue disorder likely. But replace the ascending aorta with a rigid, non-compliant decorative graft, increases stress in the arch dramatically. I guess, you know, the compliance is very important to be an elastic structure. And since you are here, it made no difference if they had a reimplantation or remodeling. The risk of dissection was the same in patient Marfan syndrome. So remodeling should not protect this. It becomes elastic in the lower part, but the stresses, I think, is due to the graft that will replace the ascending aorta.
We need a randomized trial.
I just told them that. They're going to do it. They miss the opportunity in the States.
Yeah.
But, you know, you probably didn't hear me here. I lamented to suspect that most are English trainees and English doctors here, or doctors that practice in UK. This operation was born here. But this country has one of the lowest rates of valve sparing in Europe. Even Portugal has a higher proportion than you. And Spain. Spain is pretty high. The Spanish doctors and the Germans are on the top of the list in doing valve sparing in numbers. Proportion to the patient bentos. Here is 98, 97% bentos. And Bento is an Englishman as well, so maybe it's okay.
Do we have registries?
They do. Actually, one of our fellows is presenting at the Aortic Symposium the past 20 years experience of aortic root surgeon in the UK. UK and I guess Ireland is part as well, yeah. Disappointing, I don't know why it's not. But I've been here for 3 days and talking to surgeons. Even the incidence of mitral valve repair is very low as well. Patient here with mitral regurgitation, the minority gets mitral valve repair. The system perhaps penalized the surgeon who want to do a more daring operation. But Silence. I'm sorry, I'm not criticizing your country by a long range. I admire. Listen, I came here when I was 29-year-old to spend some time with him because I admire him. I'm sorry.
I'm just joking. I haven't trained many people. The professor, yeah. Chandra, just joking. I think the big problem we face in UK is if you do anything other than ordinary, that is in the eyes of the data collectors, everybody, investigators, colleagues. If you do a mitral valve replacement, patient dies, or you did the right operation, but patient dies. You do a repair, or
You mean fear of criticism and failures and.
hello? Yeah. It's the fear. You do a valve sparing, it fails, redo, patient dies. I'll be subjected to a lot of investigation. I could be stopped from operating routinely, whatever my outcomes were. There are surgeons who have happened for one case, robotic surgery or RAS procedure, even repair. There is this fear now for the younger generation. Someone like me, senior, trained with Professor Yakub, it's okay. We grew with, before this came, we were able to face it. I have a mitral repair rate of 98%, but I can't be doing every mitral in the country because there is a waiting list issue. I trained with Prof. Yakub, but I couldn't do valve sparing because a local different problem. But now it's the biggest problem in UK is you do anything other than average AVR, you will be under a lot of scrutiny.
Well, that's
my opinion.
That's very sad because the Ross procedure was born here and you don't do it anymore. I mean, here we are increasing the number in America and Canada dramatically, and you stop doing. Valve sparing was born here. you don't do it. I mean, when I was 30-year-old, finished my training, my mentor says, if you want to differentiate yourself as a cardiac surgeon, you have to go to see in those days it was Magdi Yakub, Donald Ross, Carpentier, and Borscht. This is 1979, 78. So I came here to watch them. I was a visiting fellow. It was wasn't operating, but I was fully trained. But I came here to see what was done that wasn't done in America yet. Now it's the reverse. I mean, why are you falling behind? You should have remained the leaders in all this.
I won't be surprised if I am taken to task for openly saying this today.
I don't know if you all know the name Steve Westerby. He was very vocal for a while against this kind of big brother looking over your shoulder. If you kill a patient, if you stroke a patient, you are out of the game. I mean, if you don't take a risk, if you don't take a chance, you're not going to change anything.